Hello, everybody. Thank you so much for coming to another session. Here we have Dr. Corbett. You guys can feel free to ask your questions in the chat and also unmute yourselves if you want to. We'd love to see your face as well. So I'll let Dr. Corbett kind of introduce herself and feel free to enter your questions in the chat.
Hello. Thank you all for joining me this afternoon, and thank you for the invitation to be able to chat with you. My name is Lisa Corbett. I'm a professor of anesthesiology at the University of Minnesota. I've got about 20 years experience in the field of anesthesia, both academic and private practice. And I'm happy to share whatever information I can with you that you're interested in today. So feel free to come join us with your video and post your questions.
I have a question for you. So for me, family life is really important, and I understand in the medical field that's really difficult to find this balance. So I was wondering, what does this work-life balance look like for you? How do you define that, and how do you make that happen in your life?
That's a great question. And actually, when I went to medical school, I was a single parent. So it was especially challenging to try to find that work-life balance. There have been a lot of improvements over the years. I think it started about 15 to 20 years ago. They started putting work hour limits for students and for residents, which really greatly improved the work-life balance, especially for those in training. Because of course in training is when you have your longest work commitments time-wise. And it's important to take time for yourself. Even though you may feel like you're bogged down with homework and you feel guilty that you should be studying rather than taking time for yourself. I found out the hard way that if you don't take care of yourself, you're not going to be able to think as well, apply yourself as well, and do as good of a job for the patients as you could if you did take a little bit of time for yourself. And it's nice to see that wellness and well-being of students and learners of all ages and types is becoming very important in, I think, most programs, but especially at the University of Minnesota. They're really starting to take care of the people because they see what's happened with the fallout. I mean, there's burnout, there's suicide, there's drug use and alcoholism is, means for people that people have turned to in the past to try to just cope with things. And that's not the best way to cope with things. And that doesn't make you a very good student. It doesn't make you a good clinician. So I think now people have finally, and programs have finally started putting a lot of emphasis on wellness and well-being. So making sure that you find that time to take care of yourself is critical.
Thank you.
That's a great question. We have a quiet group today.
Hi, I have a question.
Yes.
So I recently decided that I kind of want to do I've always wanted to do medicine, and I've recently just decided to do anesthesiology. So
wonderful.
I'm particularly interested in understanding where does your passion come from? And also how have you maintained the passion to continue working for such a long time?
Well, I initially wanted to be a plastic surgeon. And I didn't see the light at the tunnel, which is actually at the end of the laryngoscope, until pretty late in medical school. I had actually known some anesthesiologists who had kind of turned me off from the profession back in the mid-90s when there was a real surplus of anesthesiologists. It was hard to find a job. So they were kind of dissuading me against going into it. And then I did my rotation, and I just realized I absolutely loved being in the OR. I had been an OR tech for 9 years before I went to medical school. And I just loved the environment. I was comfortable in the environment. I didn't have to buy a whole bunch of dress clothes and dress up every morning. And, I liked the excitement that happens in the OR, and that I realized I could still be in doing that, even though I had chosen not to go into surgery. I just had a bad experience during my surgical rotation in medical school that made me realize I was up for 41 hours straight my first day and realized I don't want to do that for 5 years. So anyway, so I wasn't sure what I wanted to do in anesthesia. When I did my rotation, and it was the beginning of my 4th year of medical school, I just realized this is where I should have been all along. I love the field of anesthesiology. A lot of people think, as I did initially, that, well, all you're doing is putting people to sleep, and then it's kind of boring the rest of the day. And then you wake them up and go to the next one, and it's kind of the same thing, but it truly, it is not. There is there are so many areas that you can work in anesthesia. And I love, my specialty area is OB. I do global health work in OB. I have traveled all around the world teaching OB anesthesia. I get to do procedures because I like to do things with my hands. So I get to do labor epidurals, I get to do nerve blocks, get to do spinals. So it's not just this boring specialty. And I think, with anesthesia is a specialty that has changed a lot in recent years, and it continually changes. And I think that's what keeps you from getting bored, because if you get bored, then you're slacking off and you're not doing current medicine because you blink and something's changed. And I love teaching, and teaching keeps the passion alive. I have to keep on my toes, or else the residents are going to ask me questions I can't answer. So by going into teaching, doing global health work, that's where my passion is, and that's what keeps the field of anesthesia exciting for me.
Thank you.
You're welcome.
First of all, Dr. Corbett, thank you for doing this. For some of us, this is a great opportunity to get clinical exposure during the pandemic. So first, thank you. I'm in an MBS program, and I'll be finishing in July of this year. So I was wondering, do you have a recommendation for a position that I could do that would help prepare me for medical school in the year between when I begin the application process and when I hopefully start?
Well, I think there's lots of opportunities to volunteer in various departments. And I know our department, actually, I think they actually hire some medical students to help out with various job duties. And we had a pre-med student who was working in our department. What was he? He was helping out with like the resident education and things. So I think a lot, whatever area you think you might be interested in, and things, people change their minds all the time. Again, I started out, I was going to be a plastic surgeon, and I'm now an anesthesiologist, and I've been very, very happy with my choice. So you never know what you're going to go into, but feel free to reach out to me or any other people in any of the departments, and see what's going on in their department as far as possible either job or volunteer opportunities.
Thank you.
You're welcome.
Hi, Dr. Corbett.
Hi there.
Could you describe to us what your day looks like as a anesthesiologist that specializes in OB?
Sure. So I show up at 6:30 in the morning. That's the time that we have decided to have be the change of shift. And I get a report from my colleague who worked overnight on all the laboring patients. And then at 7 o'clock, we have a group meeting with the obstetricians and the midwives and the charge nurse on labor and delivery. And they go over all the patients who are in the hospital in labor and delivery, or on postpartum, or on antepartum, which is where women stay before they have their babies if they are high risk or have some sort of illness that requires them to be hospitalized. So we go through the list of all the patients and discuss any concerns we have with any of them, or if there's a patient who I feel needs a particular lab before they get our services, or they might need to have IV access. That's our time to communicate those things as a group. And then we usually have elective cases that are booked starting at 8:30 in the morning. So it could be a C-section, could be a cervical cerclage for cervical incompetence for women who have had preterm deliveries in the past. And so they're trying to, they put a suture in the cervix to try to keep the pregnancy going longer. or it could be fetal surgery. We've been starting to do some fetal surgeries, which I really find fascinating, and just did one yesterday, gave anesthesia for that. And so we'll do elective cases in the morning, and then we may get called at any time for labor epidurals for people who are women who are ready for their labor epidural. And at any time, women can come in from outside. They may be bleeding, they might be laboring, but they've had a C-section in the past and don't want to risk a uterine rupture, so they need C-section pretty quickly. So I like OB because it's not the same thing. I like excitement. I like change. I don't like monotony. And so in OB, you never know what's coming in the door, and you have to be prepared for anything and any emergency at any time. So we do certainly have our share of patients who come in and change our day up from what we originally planned in the morning. And so throughout the day, that's what I do. I medically direct residents and teach residents how to do labor epidurals, how to do anesthesia for the various procedures, which are primarily C-sections, but we do the occasional other procedures. And then when we have some downtime, I teach the residents. I teach them. I have probably 30 different PowerPoint presentations on various areas of OB anesthesia that I like to teach. And then typically our day is done by 3. That's when we have our next shift change for the call person coming on. So we turn over OB to the call person.
Hi, Dr. Corbett. You mentioned before how you were involved in global health, especially obtaining to obstetrics. So I was just wondering like how you got involved in that and kind of what that involves and what you do to help out with that.
Sure. So I'm involved in an organization called Kybele. It's Kybele. It's not the sporting goods store. If you're interested in looking it up, it's kybeleworldwide.org. And I got involved initially. I've always been interested in global health, and I love travel and I love teaching. And I heard the founder of Kybele speak in 2006 at an annual meeting for the Society for Obstetric Anesthesia and Perinatology, which is the SOAP meeting. And she was talking about the work that she had been doing in Turkey and that they were starting in Ghana. And she said, if anybody's interested in doing work with the organization, to look her up there at the meeting. So I went up to her and I said, wow, this is education, this is obstetrics, this is travel, this is all, but by 3 passions. So I said, I'm happy to join, to go wherever and do whatever. So it's kind of funny because she said, well, we're doing we're planning a trip in September to Republic of Georgia and Armenia. And I said, great. And I had no idea where they were. My geography was pretty bad. But I was like, yeah, great. Wherever you can use me, I'm happy to go. So I went home, looked at an atlas and went, wow, that's not quite where I thought it was. But I had the best experience. It was actually a site visit. So what we do is go to a country where we're asked and go to the hospital and see how they do things, see how they do their OB anesthesia, see what supplies they have, see what medications they have available, to see where we can help. Because what we try to do is we try to promote regional anesthesia because it's far safer for the mothers for C-section. And we also like to teach them ways to provide the women painless deliveries, which in a lot of countries is not the case. They don't offer women any form of analgesia during labor. But we don't want to come in and tell them, do this exactly the way we do it. This is how you have to do it, because it's not realistic most of the time. They don't have access to the equipment or the supplies or the medications that we have. So we work together with the hospitals, and then we've also usually meet with the ministers of health to try to get medications approved that are not approved. So when we went to Georgia and Armenia, we met with the health ministers there, and the work kind of ended up focusing on Georgia for a little while because they didn't have the right infrastructure in the Armenian hospitals at that time. But several years later, we went back and did the same stuff in Armenia. But we met with the health minister because bupivacaine, which is a very common medication we use for labor epidurals, we use it for C-sections, was illegal in Georgia. Now, this is a local anesthetic. It's not a controlled substance, but for whatever reason, it was illegal. And so they were getting it from Russia, the Russian black market. And, there was no control over what is actually in the medication. And so it was kind of scary to think of putting that in spinal fluid and what potential dangers that can do. So we met with the health ministers, and the next year when we went back to follow up, bupivacaine was approved. So, we felt like we really moved their anesthesia opportunities forward with that. And we go back typically once or twice a year, follow up on the work we're doing, find out where they're meeting roadblocks and see how we can help them overcome those. And it's just absolutely amazing. So I've been to Georgia, Armenia, Romania, Turkey, and Ukraine is the current team I lead. Unfortunately, with COVID, we haven't been able to travel, but we actually have still been doing Zoom lectures for regional meetings that they have. And we're planning, we're just waiting for the borders to open up and this darn pandemic to slow down so that we can go back. And, we take not only physicians on our teams, but we do take residents to teach their residents. We have taken students on trips that the students can't practice medicine, but they can help coordinate things. We have people who do shopping for items that we can sell in a Cabela store to raise money for trips. And so there are other things, and there are also some scholarship opportunities for, there's right now applications for a Cabela soap scholarship. I think it's $10,000 to come up with a research project to help promote improved maternal health and safety, and it would involve going on several of the trips. So our organization has other current trips and projects that we do in the Balkans with Serbia, Macedonia, and Bosnia, and then the Ghana trip is a big, long-going effort. I can talk for hours about that, so I'll stop now.
Dr. Corbett.
Yes.
I'm sorry, I don't want to put myself on camera because
That's okay.
But okay, so like, in undergrad, did you ever have like intense feelings of like giving up? Like I've been experiencing this for like the past week. I don't know, because I started Chem 2 and I feel like I don't know Chem 1, and then now I'm doing something with like environmental sampling and statistics, and I don't know. I feel like because I want to go the PA route, and I ended up in such a complicated predicament, but I'm near the end of my prereqs and also near the end of my bachelor's degree and stuff like that. But just experiencing like intense feelings of like, I don't want to do this anymore, but I still want to be at PA, but I just don't want to do these equations, So did you ever feel like that? And I just need to know how to conquer that and move past that, because sometimes I feel like I cannot, like in my mind today, I'm just like, should I just drop out?
Well, first of all, I say don't give up.
I'm so far, like I'm over 120 hours like to finish my entire degree. So it's like, I can't give up.
Yeah, no, I would say absolutely your time and efforts are worth not giving up over. I had it pretty rough. I was, like I said, single parent. I was working 2 jobs, 60 hours a week and taking 19 credits a semester. And there were many times I felt like giving up. But I chose to keep going and to keep pushing, because I knew that if I gave up, I didn't know what else I wanted to do. And I thought, I've put all this time and effort in, and if I give up, then all of that was for nothing. If you have that passion to be in healthcare, it's something that not a lot of people have. I mean, you think of all the other people out there that are doing all sorts of other things. When you have that passion, there's a reason that you have that passion and that drive. And nothing comes, it's not going to come easy. There will be times when you will just want to throw in the towel and say, this isn't worth it. in the long run, it will be worth it. And so I just, take time for yourself. Sometimes you just have to take a breather, and you'll feel like, oh, I can't see the end of tests and studying and reading and writing papers and things. Sometimes you just have to take a night off or a weekend away and just put your books away. So like a weekend away from your books and studying, and just take time for you. Sleep in, watch a favorite TV show, or, I know with the pandemic, it makes it a lot more challenging to go out and do things, but try to get some fresh air, go for a walk, take care of yourself, do something you enjoy doing that has nothing to do with school. And it'll help you to reset your mindset. Things, no matter what career you go in, there will be times that you just are frustrated. You're starting to get burned out from either studying or working, and just, you need to take a step back. Take a step back, take a day off. Just, it allows you to reset. So that would be my best advice, is just make sure you, and it sounds like you're probably about at that point where you really should just take a day off. And then don't let it make you feel guilty that you've taken the time away from studying, because it's very easy to fall into that trap where you'll feel guilty, like, oh, I have to study. If I don't study, then, oh, I could have done better on my test. But you probably would have been worse if you just kept going and didn't take any time for yourself. So take time for yourself, take care of yourself. That way you can apply yourself the best the next day or a couple days later when you're ready to get back on the horse.
May I add something to that?
Absolutely.
So I think Holly is her name that just spoke.
Mm-hmm.
So there's this quote that I always read every single day. It's from Steve Harvey, and he said, "If you're going through hell, keep going. Why would you stop in hell?" So
That's
I know,
nice.
yeah, I know it's tough, but just keep in mind the countless of patients and people that you're going to be helping in the future, and that should push you to want to do your best, because at the end of the day, those people are going to benefit from the countless hours of hard work you're putting in right now. They're going to benefit from that because you're going to be helping saving thousands and thousands of lives. So
yeah,
just thought I'd add that.
Absolutely. Thank you for sharing that. I love that quote. I might use that in the future. Yeah, it's not, going into healthcare profession is not an easy road. And I won't, say that, yes, it is. It can be tough, but it is so rewarding. And there are far, far, far more good things than bad. The worst part is just getting through all the studying to get there. Once you finish and you're able to start your career, you'll find yourself being blessed every day, whether it's by positive things that patients tell you, how you have helped them, how you've impacted their life, by people who you are now teaching, you're sharing and imparting your wisdom. People will tell you the most rewarding things for me are when I get cards from people who I've taught thanking me for what I've taught them. So you'll get to the point where you will be the teacher, and you will change far, far more lives and impact far, far more lives than you'll ever imagine. So it's worth it. It's worth it to stick with it. If you have that passion for healthcare, no matter what area of healthcare, stick with it, because it is a gift, and in the long run, you will be rewarded many, many times over for the hard work and efforts you've put in.
Hi again, Dr. Corbett. I just wanted to let you know you had a couple questions in the chat.
Oh, okay. Let me see. All righty. All right. I like the quote that Annabelle put here. You didn't come this far to only come this far. That is a great quote. You will be going much farther than you ever dreamed. Okay, Adrian had a question here. Can you talk about a memorable experience with a patient that will stick with you forever? There's one patient who I don't think I will ever forget. I actually wrote a short story about him in my last year of medical school when I took a literature and medicine rotation. I had a patient who came in the middle of the night who I went to medical school in Miami, and he lived in a little camper off like in the Everglades. And he came in, and I was on an internal medicine rotation on call and had to work him up. And he was about the color of a banana. He was so yellow, so jaundiced. And he was this gruff old man who, had a big unkempt beard, was quite obese, and just not very friendly to the people who were going into his room to take care of him. Well, he reminded me of my dad, who I knew was just a big teddy bear inside. So I kind of have a little place in my heart for, gruff elderly men who, try to act like the tough guy. And so this patient turned out we found he had a terminal pancreatic cancer. So I had to share this news with the patient and, tell him that this was, a terminal diagnosis. We did our best to give him pain relief because he came in for abdominal pain. He had obstructed his bile ducts, and so we had to take care of that. That was the number one thing. So we got that taken care of, but I couldn't see him discharged to a camper alone. That just broke my heart to think about that. Well, it turned out he had a daughter who he had not seen in years. He was estranged from her. And his grandkids, who I don't remember if he had ever even met them, and they lived in the area, but he, for whatever reason, was estranged from his daughter. And so when each day I would spend some time in his room talking with him about his life and things. And I had told him, that I would like to invite him to my medical school graduation, which was just several months after I had him as a patient. And we bonded, and I actually finally got his permission to contact his daughter, because at first he told me he didn't want anybody to know what was going on with him. And I convinced him that his daughter would want to know. And I actually got them reunited, and then he moved in with her. So he didn't die alone, and he only lasted about 2 months after he was discharged. But I felt like he taught me a lot about not giving up on patients, and really just taught me a lot about myself as a person, and that, I can make a significant difference. This is somebody who would have been discharged and died alone in a camper, and I was able to reunite him with his daughter, and he was able to die comfortably in a nice, comfortable bed in her home with his family surrounding him. So that's someone who I will never forget. He was kind of my first really, the patient that I first really bonded with in that fashion, and felt like I truly made a difference in his life, and felt like medical school, if nothing else, medical school was worth what I was able to do for him. All right, let me see. How did I manage debt from medical school? That's a good one. When you get out in practice, your first couple years are, you're making very good, you're putting the large majority back into managing the debt from medical school. There are a lot of scholarships out there. There are a lot of loans for medical school. And one thing that I was told before I started, because I was concerned about how am I going to pay for medical school? How am I going to get through? And I was told that if you make it into medical school, the school will help you to be able to find sources to pay for your education, because they want you to succeed and they want you to finish. It doesn't look good on the medical school if they have students who are not completing and not graduating because they don't have the finance. It doesn't look good on the medical schools to not have people graduate anyway, but because they're getting a lot of state aid for each student. So they are they have a lot of incentives to keep the students going. And if it's loans that you have to pay back, you will be making plenty enough money when you graduate to pay back those loans without difficulty. All right. Well, you're welcome. I love sharing stories about medicine. I had another patient who was very, you'll have patients who just touch a special place in your heart. And I had one who had some congenital, serious congenital heart condition. And she was a pregnant patient. She came in, I saw her to help decide an anesthetic plan for her cesarean section. And she is a person whose medical condition was such that she never should have been pregnant. She was told never to get pregnant, but her desire in life was to be a mother. And so she came to me, and she was going to be a big anesthetic challenge to get her safely through the C-section. And we were able to do so. The obstetrician and I both begged her to let them tie her tubes so she wouldn't get pregnant again, because it was a risk to her life. And she said no, she wanted to have lots of kids. And so her husband was in the military, and so I never met him while she was pregnant. And she came in a year later, pregnant again, even though she'd been told, not to get pregnant. And her heart condition was significantly worse the second time. And I, talked to her again, and the obstetricians talked to her, tried to get her to agree to a tubal ligation, and she refused. And then she came in for her C-section. I gave her the anesthesia for that. We had her in a cardiac room where we had the bypass machine standing by in case we had to emergently do heart surgery on her. I had the heart surgeon standing by, had everything ready. The surgery went beautifully, couldn't have gone more textbook. However, we took her to the ICU afterwards, and about an hour or 2 hours later, she went into fulminant congestive heart failure, which was the biggest risk. And they had to rush her down to the cardiac operating room and put her on bypass machine. And they couldn't get her off the bypass machine, so they had to place an LVAD, which is a special device that helps to pump the heart. It's artificially pumping the heart. And took her up to the ICU afterwards. So I didn't think she would make it overnight, but I got there the next day, and she was awake and she was alert. She was intubated, so she couldn't talk, and she had this LVAD machine going, but she was awake and alert, and which she was beating all odds. And then they decided to send her down to Austin, Texas, where we were was about an hour north of Austin. And so she, they were sending her down there for a heart transplant, to put her on the heart transplant list for an emergent heart transplant. But in order to do that, they have to anticoagulate the patient. So being on this LVAD, you have to have the blood thin, or else it's going to clot in the machine, and that would kill a person. So they have this, all this medication in there that keeps the blood thin. Unfortunately, a side effect is it can cause bleeding in the body, because that goes through the body as well. And she had a hemorrhagic stroke, and it made her in a condition that was incompatible with life. And they pulled the plug basically 2 hours before her husband's plane landed from Iraq, which was very sad. And that's the only patient's funeral I've ever gone to. So you'll meet patients that, I felt very bonded to her because I had taken care of her now twice for 2 different pregnancies. And that's things like that stick with you. So you'll have very good experiences where you'll have patients that touch you in a positive way. And both of these patients touched me in a positive way. But the outcomes were not good for her. It was really bad. But she, at her funeral, her husband said, she left me with 2 beautiful gifts, which were the children. And so anyway, that's just a story that I like to share with people about patients that can touch you.
If I can ask, speaking on that, where do you find the like threading the line between being too desensitized, especially going into many decades into your career, versus
Mhm.
still holding that empathy to be a good doctor that still cares?
It's difficult, and you have to choose an area of medicine that is going to be conducive with what your emotional ability is. I could not go into a profession where, like oncology, where you are dealing with terminal illnesses, and a significant percentage of the population will probably die, because I get too attached to people. So anesthesia, some people think anesthesia, you don't get attached to your patients, but we get a very intense relationship very quickly and very briefly in anesthesia. So we meet the patients, we meet their families. These patients are relying on us to get them through the surgery safely. And when something bad happens, it takes a little piece of you. And you question yourself, and you question, should I have done something different? But you have to understand that, if you're trained to do your job, you're doing the best job you can. And there are underlying conditions that patients can have that are not always preventable. Like I had a surgical case where the surgeon didn't realize the tumor, a kidney tumor, was had grown into the vena cava. And so when he went to get the went to get the tumor out, and he put his hand around, it ripped the vena cava apart, which is a non-operable lethal event. And that was very hard for the surgeon. The surgeon was really struggling when he had to go tell the family this happened, because he felt it was his fault, although it wasn't, because the tumor had grown into the vena cava. That was not something that was resectable. I felt horrible because I couldn't get blood fast enough, because we didn't have a blood bank at the hospital. It was a little community hospital. We had a couple units of blood, but we didn't have like an entire blood bank available like we do at the hospital here, where we can get almost unlimited units of blood. And so I felt partially responsible because I couldn't resuscitate the patient, because I didn't have the equipment and the blood available to me. So it's, death is inevitable, bad outcomes are inevitable, but hopefully they're extremely rare. And you will, if you're a decent human being, you're going to feel when that happens. But you have to stop and tell yourself, I did the best I could. I feel very bad about what happened, but I did the best that I could for this patient. And now I have more patients who need me, and I have to focus on the next patients that need me. And if there is something that happened that was because of an error, just remind yourself that we're human, and humans do err at times. And don't ever hesitate to reach out to the hospital's resources that they have to talk to, because sometimes, especially if an error happened, it's going to be very, very difficult to, if you keep telling yourself it's your fault, and it's my fault, I shouldn't be practicing medicine, I shouldn't have done that, I should have known better. But we're all human, and things happen, especially if you're up late at night, you've been up many hours and you're tired. Medication errors can happen, different things can happen, but nobody's going to be looking at you like you're a bad person, because we've all been there. We've all made mistakes. I've made mistakes. Thankfully, they have not permanently harmed a patient, but things happen because we're human, and you have to know where your resources are to go to talk to, because there will always be people that the hospitals have whose job it is to help any of the healthcare professionals, whether they be nurses, PAs, nurse practitioners, physicians, CRNAs, anybody who has been through a traumatic experience with a patient and needs someone to talk to. I hope that answered.
Yes, thank you.
You're welcome. All right, we have Stephanie's asking about PA school and the role of PA when working in anesthesiology. The route for anesthesiology is through a CRNA program, which is actually a nurse practitioner, not a physician assistant. We do have physician assistants who do work in our department, who do our screenings in our pre-anesthesia clinic, and they do the H&Ps. So they see the patients in our pre-anesthesia clinic and do histories and physicals on them. They gather all of the information and data in the chart that will be important for anesthesia to ensure that the patient is optimized and in the best health they can be for surgery, or to recognize if they need additional testing of any sort, whether it's labs, x-rays, MRIs, CAT scans, additional consults from specialists, and get those patients optimized for surgery. So we do have PAs that work in that clinic. So the scope of practice for a PA, they're not doing clinical anesthesia, they're doing the histories and physicals and optimization of patients for surgery. So as a CRNA, which are the allied professionals for anesthesia, are the nurse anesthetists or anesthesia assistants. So anesthesia assistants and nurse anesthetists basically do the same job, but they have different supervision requirements. So an anesthesia assistant can be someone who has any background. You can get an undergraduate degree in anything and then apply to anesthesia assistant school. So the anesthesia assistants practice anesthesia. They will put patients to sleep. They'll put in spinals. They'll take care of patients under anesthesia during surgery, but they have to be medically directed by an anesthesiologist. Nurse anesthetists are a nurse practitioner background, so you have to have a degree in nursing. You have to be an RN with a bachelor's degree, BSN. And then they go on to an additional, they have to have, and it's changed some, but it's somewhere around 2 years worth of ICU experience. So they get their nursing degree and go work for several years in the ICU, and then they can apply for a CRNA program. And then they get their master's in nurse anesthesia. And they, depending on the state, in some states they can practice independently, so they don't need an anesthesiologist medically directing them. They can work independently, just like an anesthesiologist can work independently. They can work as well, but they do have prescription. They can write prescriptions, but the prescriptions can't be for controlled substances. So that's one difference from an MD. And in some states, depending on the licensing you have, they are not allowed to write prescriptions. However, they are giving the medications that we use in anesthesia, we don't write prescriptions for, but we are responsible for. Does that answer that question?
Yes, thank you so much.
You're welcome. All right, how has COVID changed OB anesthesia? Well, we have to wear PPE. It was interesting when COVID first started, the obstetricians I worked with were concerned about women laboring. And when they get to the point of pushing, as to whether or not that was an aerosol generating procedure. So with anesthesia, we're considered one of the frontline people because we do intubations, and intubations are aerosol generating procedures. So the biggest concern with spreading COVID is the aerosolization of the virus particles. And that is, as I'm sure you're well aware, coughing, sneezing, anything that will shoot those particles out of the airway and make them airborne are what's going to infect somebody else. So in anesthesia, placing an endotracheal tube or intubating someone and taking that tube out, which causes them to cough, are the high risk times. So the hospitals weren't even thinking about laboring patients and the birthing process. But the obstetrician said, well, when these patients, they're in there and they're pushing and they're screaming, they're exhaling forcefully. And so I think we need to treat these with the full PPE, just like we do when we're intubating somebody, because of that potential for spread. And it took a while for the hospitals to kind of come around and acknowledge that, yes, that could very well be a method for spreading. So it's not any different for OB than it is the main OR. So we have to wear our full N95 masks and our face shields and gloves and a gown when we're in a COVID positive patient's room, even just doing an epidural for labor, because if she's screaming, or if she, with pain with the contractions, or if she's getting near the time for pushing, she could potentially be aerosolizing the virus particles. And we've had a number, but they've all done well. All right, let's see. You're ever scared to do anything in your field knowing that anesthesia can hurt a patient? Yes, I actually have had a number of instances where I've been very concerned about a patient and whether or not they would be able to get through anesthesia safely. I had a patient who was scheduled for this extensive spine surgery. So it was going to be multiple hours long. And the patient was an elderly patient who was wheelchair bound because of very bad lung disease. And so one of the things that we get concerned about with anesthesia is if the patients have poor lungs and we have to intubate them for surgery, are we going to be able to remove the breathing tube at the end of the procedure? Because anesthesia can make their lungs not function quite as well temporarily, which is not a big deal for people who are healthy. But people with bad lungs, the concern is, are you going to have to remain on a ventilator for a prolonged period of time afterwards, or even if you will ever be able to get off a ventilator? So I had this patient, his lung disease was so bad that he was wheelchair bound. He was oxygen dependent. I think his lungs worked about 30% of what they should have been working. And he was going to have this long spine surgery. And I said, and as an anesthesiologist, I have to tell patients the risks of anesthesia. Sometimes they don't want to hear them, but I have to tell them. And this patient, I explained, the risk of having to be on with a breathing tube afterwards and on a ventilator in the ICU. And he said, well, for how long? And I said, well, I can't tell you that, possibly permanent. I said, your lungs are in very poor shape, and I don't know that I'm going to be able to remove the breathing tube at the end of the case. And I can't tell you, if it's a temporary thing or a permanent thing. That's just something that you have to think about. And he said, well, I don't want to have that. And I said, well, you have to make that decision as to whether or not you feel like your back pain is worth the risk of possibly being on a ventilator long term, and for an undetermined period of time. And he ended up canceling his procedure because he felt that that risk wasn't worth it to him. And so, I try to tell people, I don't like to scare people, but if somebody is really at high risk for something, I do want them to realize that. And yes, if I had to do anesthesia for him, I would have been very concerned that I wouldn't have been able to extubate him at the end of the case. And I would have felt really bad if he ended up on a ventilator long-term, knowing he didn't want that. And there have been there have been times when there have been medication errors. And I have been scared. When I was first learning, it was my first or second day in residency. And one of my colleagues handed me a syringe and said, here, give this. And I gave it IV, and it was a local anesthetic that was supposed to go in the epidural. And I almost quit that day. I almost quit anesthesia because I thought, this is so scary. I could kill somebody without even knowing, just in a split second, making a stupid mistake. I could kill somebody or significantly harm them. I was so scared that day that by giving that medication IV that I actually killed the patient, that I went home and I contemplated whether or not I wanted to continue in anesthesia because of the risks, the risks that you, but I can tell you that for the last 20 years, that was 97, so 23, 24 years, I have looked at every single syringe I give a patient to make sure that I know exactly what I am giving and that I'm giving it in the right route. So you learn from your errors. Everybody's going to make errors. You learn from the errors. That is what you do. You learn from it and you move forward, and you vow just not to ever make that mistake again. And you usually don't make the same mistake twice. But again, we're all human. You will make mistakes. The biggest thing is to know what to do when you make that mistake to get the patient through it, and then learn from it and teach. I tell all my residents my stories of the mistakes I've done so that they can learn from them and hopefully not have to go through that particular thing themselves.
Okay, I think that was all, unless anyone has a last minute question they want to put in the chat or just say.
I actually did have one more question.
Sure.
When you were going through clinical rotations, Dr. Corbett, if you didn't choose anesthesiology, what were some of your favorite clinical rotations, and what would you have chosen if you didn't choose anesthesiology?
Well, I still love plastic surgery. But it was because the surgery residency was going to be so tough that I chose not to do that. I loved genetics. I was just fascinated by that. And so I worked with a geneticist for a month and saw all his patients in clinic, which involved genetic counseling for pregnant patients for their baby who are at high risk for congenital anomalies. I also really enjoyed, I had a forensic pathology course that was in Miami. So it was with the Dade County Medical Examiner. Again, I really like that. I would probably do that. The forensic pathology was really fascinating. Trying to, be like a detective and figure out what happened. I went out to crime scenes and it was a little gruesome, but I found myself just very drawn to the investigative part. I just thought that was, how they can determine cause of death, manner of death of patients was pretty intriguing.
Thank you.
You're welcome. Well, thank you all very much for all these great questions, and hopefully I might have been able to enlighten